Welcome to AJT's webinar on T-cell mediated rejection in lung transplant. We're delighted you could join us for this live panel discussion. You'll be able to find a pre-recorded session with Dr. Ramsey Hakem and John Belperio discussing their findings on the AJT website. Today's discussion will focus on the implication of these papers. I'm John Greenland, Associate Editor at AJT and Associate Professor at the University of California, San Francisco. And I'd like to welcome my co-host, Dan Kreisel.
Thanks, John. My name is Dan Kreisel. I'm at Washington University in St. Louis. I'm a thoracic surgeon, and I'm a deputy editor with the American Journal of Transplantation. We have 4 internationally recognized experts in lung transplantation as the discussants for these 2 papers, and I'm going to ask our discussants to introduce themselves, and I'll go around. Rob?
I'm Rob Fairchild. I'm a transplant immunologist at the Cleveland Clinic.
Robin?
Hi everyone, I'm Robin Vos. I'm a transplant pulmonologist at the Leuven University Transplant Program in Belgium.
Sean?
I'm Sean Agbo. I'm an associate editor for AJT, a tenure track investigator at the NIH, and I'm also an adjunct faculty at Johns Hopkins Lung Transplant Program.
Thank you, Sean. Christine?
Hello, I'm Christine Falk. I'm an immunologist and head of the Institute of Transplant Immunology at Hanover Medical School. I'm very happy to join this session.
Thank you all. So as John just said, we have 2 papers, and there's a pre-recorded webinar with Ramsey Hashem and John Belperio discussing the papers that we selected as 2 important papers in the lung transplant field that have been published in the AJT recently. And John and I will just briefly summarize those 2 papers in a minute, and then we'll have some questions for our panel. The first paper that we will be discussing today is entitled A Pilot Randomized Controlled Trial of de novo belatacept-based immunosuppression following ATG induction in lung transplantation. The first author is Howard Wong from Methodist in Houston, and Ramsey Hashem from Washington University is the senior author. And briefly, this is a 2-center pilot randomized controlled trial of de novo immunosuppression with belatacept in lung transplant patients. The study was conducted at Washington University in St. Louis and Methodist Hospital in Houston. And based on results of trials in kidney transplant patients, the authors hypothesized that belatacept would decrease the development of DSA and reduce CLAD. All patients, based on previous reports and other studies where there was a higher rate of acute cellular rejection, received induction therapy with ATG, and then patients were randomized to 2 groups. The treatment group received belatacept, tacrolimus, and prednisone with conversion of TAC to MMF on day 89, and the control group received maintenance immunosuppression with TAC, MMF, and prednisone. The study was terminated prematurely due to a high incidence of deaths in the belatacept arm compared to the control arm. 5 out of 13 patients in the belatacept arm ended up dying versus none in the control arm. The causes of death in the belatacept arm included COVID-19, restrictive allograft syndrome, which was preceded by an infection with rhinovirus. A patient suffered from a hemothorax, and of note, the patient had received belatacept a few hours before the development of the hemothorax. 1 patient died from a pulmonary embolus, and 1 patient died from PTLD. There was no difference in freedom from DSA development, freedom from acute cellular rejection grade A1, infections, or serious adverse events. John?
Well, we'll also be discussing Dr. Shino and colleagues' study based on data from the CTOT-20 multicenter observational trial. Here, they quantified interferon gamma-dependent cytokines, CXCL9 and CXCL10, in lung transplant recipient BL fluid. The key finding here was that these CXCR3 chemokines were increased in association with several pathologies in the lung allograft, in particular with acute vascular rejection or airway rejection, as well as acute lung injury or infection, but not increased with organizing pneumonia. And this study is worth noting in context with the follow-up paper that just came out in September's issue of the AJT, which showed an interaction with these pathologies, elevated levels of these cytokines, and the development of CLAD. So, shall we turn to our first question?
Yes. So I'll start with the first question for Sean. And Sean, do you have any thoughts what could be responsible for the higher mortality rate? I realize it's a small number of patients and the trial was terminated prematurely, but do you have any thoughts what could have led to the higher mortality in the belatacept arm? And do you think that's directly attributable? Can this be directly attributed to the belatacept?
So Dan, thank you for that very interesting question. You're quite correct that the numbers of the patients are small, so it's very challenging to draw conclusive statements. However, let me see if we can start from where the mechanism of action of belatacept is. Belatacept, in the activation of T cells, you need binding to the T cell receptor and a co-stimulatory activity. That the combination of T cell activation plus the co-stimulatory stimulus is necessary for T cell function. Belatacept is a humanized antibodies that binds to the co-stimulatory arm, preventing the activation of T cells. Then these T cells generally would undergo apoptosis. Now, coming back to these patients, why did these patients die? You've identified the causes for the death, and the numbers are very small. You would notice that the 5 patients who died all died from different reasons. 2, you can associate them to viral infections, whether it's COVID-19 or respiratory allograft, some restrictive allograft syndrome that preceded a viral infection. One that's PTLD, and another that's a PE, one that another patient that then one additional cause. If you look at the profile of infections in the patient's case control, asking the question, could this belatacept predispose these patients for infection? Seems like the rates of infection in both cases were similar. Number 2, data from kidney transplant, looking at that also in randomized control trial that included belatacept, the rates of infection in both arms were also similar. The patients did not seem to have very severe infections. It would make one suggest that, oh, is belatacept responsible for this infection? Again, the data, the jury is out there. And one other patient developed PTLD. Well, again, looking at data from the kidney literature, wherein they pooled multiple studies and had about 1,500 patients. So it seems like a big study. In that cohort, about 18 patients out of the 1,500 developed PTLD. Out of that 15, only 2 were from the MMF or mycophenolate arm. 13 of those subjects were taking belatacept. While the numbers were small in this big cohort, the development of PTLD was found to be associated to the use of belatacept in this large population of kidney transplant patients. So coming back to this trial, I think the jury is still out. Could belatacept be associated to these causes of death? Whether it's viral, PTLD, the hemothorax, I think the numbers in lung are too small. However, maybe we could borrow data from some other sites to make some suggestions. It is hard to draw a conclusion based on the current numbers and the findings of this study.
Thank you, Sean.
Anyone else on that want to comment? If not, maybe I'll turn to Dr. Fairchild.
Maybe I just
Yeah.
I just would briefly comment on that. I think it's a very nice comment in the sense that the Epstein-Barr virus can create problems under immunosuppression, especially when there are EBV negative recipients. So question would be whether also with other transplants, especially in the liver and the kidney field, sort of there could be one way to sort of check that in advance by having EBV positive recipients. And this is one of the viral constellations where the study probably only one case, but has shown how important it is that the EBV positivity needs to be set if you have co-stimulation inhibitors, because the naive T cells would require co-stimulatory signals. If they can't, they may not be able to generate virus-specific T cells. That is just adding to the very important point. Thank you.
Agreed. Well, now can I turn to Dr. Fairchild and ask if you think there's a path forward for belatacept in lung transplant? And also, can we learn from immunosuppression studies in mice? I know co-stimulatory blockade has certainly been used a lot in animal models, at least in mice. And one could ask the question whether the mouse models are sufficient or if we need primate models as well.
Well, there's a couple thoughts that come to mind right off the bat. And one is that this is an observational study. We don't know how the belatacept treatment is affecting de novo priming of donor-reactive T cells. That wasn't looked at, but there's another layer of complexity, and I agree with Christine. No viral specific responses were looked at as well in the treated patients. So we don't know if the belatacept had any positive efficacy in the treated patients at all, actually. But the other level of complexity that I'm alluding to is that a lot of populations of memory T cells are resistant to CTLA-4 Ig-mediated inhibition, and can easily cause acute rejection. And since you've mentioned mice, this can happen in mice as well as in humans. We know from the benefit trial that about 5 to 8% of those treated patients were having these raging acute rejection episodes when they were switched from a calcineurin inhibitor to belatacept. And the other thing is that these memory cells may not even come from the recipient. A lot of lungs, in fact, probably most lungs in these transplants harbor a cohort of resident memory CD8 T cells in the graft tissue as well. And no one has ever asked what happens, how they're activated, what are the mechanisms of activation, what is the impact of CD28 mediated co-stim blockade on their activation. So I would say, to the second part of your question, there's a lot we can learn from mice, but and we have. So I don't think we should just dismiss studies in mice just off the cuff. But I do think that we need studies on non-human primates too, where we can study all these different layers of memory cells, many that are going to be resistant to belatacept. And again, as Christine said, we need to know what the belatacept is doing to the de novo response to the viruses. The last point I'll make is, remember that there is probably a high degree of heterologous immunity in these lung transplant patients. We're starting to look at that now, where that the memory repertoire that a recipient has may cross-react with donor HLA molecules, may also cross-react with viruses too. That was where the first observation of this immune phenomenon was made. So we need to try to incorporate good models that encompass all those kinds of things.
I guess just one follow-up point there. Mouse models here tend to use double co-stimulatory blockade, which was not what was trialed here. Is there reason for optimism about double co-stimulatory blockade strategies in lung transplant? Or, does these data really sort of diminish enthusiasm for that approach?
Well, I think mouse immunologists use the stuff that works so they can get the papers published. That's the primary goal. remember how potent that would be to use a two-armed targeted co-stimulation blockade. I think it's important to remember now too, since we're talking about this, that there are a lot of new reagents that are beginning to emerge on the market. There'll be clinical trials and transplant on these. These include antibodies or other antagonizing reagents that disrupt CD40, CD154 targeted co-stimulation without the thrombocytopenic effects, OX40 ligand mediated co-stimulation, ICOS mediated co-stimulation. So there's a lot of new things that are going to be coming, and I think we need to seriously think about this, and I'm sure we will.
Yeah, one point for what it's worth, in the mouse, CTLA-4 alone does not prevent rejection, but in combination with blocking CD40-154 in mouse models, we do get long-term survival, but we haven't tested the combination of CTLA-4 with cyclosporin or others in the mouse model. Christine, if I may, I want to follow up a little bit on what Rob just alluded to, and specifically the tissue-resident memory cells. And Dana-Farber published some beautiful papers showing that there's a combination of donor as well as recipient T cells that become tissue-resident memory cells in lung transplant recipients. And Andy Gelman just published a paper in JCI a month or 2 months ago showing that activation of tissue-resident memory cells by monocyte-derived macrophages leads to chronic rejection in the mouse model. Now, we know that the lung has a large repertoire of these cells. And can you maybe elaborate a little bit more on belatacept or immunosuppression in general, that it needs to target these cells specifically, perhaps in the lung more so than in other organs?
Yeah, thank you. There was actually the sort of questions that came to my mind when I was reading the paper, because the lung is really bringing its own donor repertoire of tissue-resident memory cells. And by definition, they are memory cells, so they are negative for CD28, CD27. We've been looking into this compartment. On the phenotype, they have PD-1 on the surface. They do have CD103, CD69. So they have a peculiar phenotype, as Dana-Farber has described. And now if you apply co-stimulation blockade, I think they should be sort of, you could say, resistant, because there's no CD28, and CTLA-4 belatacept should not interfere with those. But belatacept also may have sort of, in the course of CTLA-4 mediated interaction with the B7-1, B7-2, it could be that there is a different kind of effect using this drug on the lung compared to the kidney, for example, where you have much less tissue-resident memory cells. And so I'm really wondering whether, as you mentioned, there are other co-stimulatory blockade potential candidates, whether this would be something to consider, especially for the lung. The liver would be another sort of issue, but here in the lung, one could really benefit from the single-cell sequencing data from Dana-Farber and others showing that these cells have really a special phenotype, T-cell receptor repertoire, and maybe the belatacept would sort of not create a sort of optimal co-stimulatory blockade, because it would affect probably the cells moving into the lung, but not the ones that are resident, and we don't know actually what their role might be. So I think that especially the lung with its unique compartment might even have a broader thoughts to other co-stimulatory candidates, although it has not been really formally shown that this would be a step for the future. And I would totally agree, large animal models would probably help to solve one of these key questions. And therefore, I would strongly also argue to look always in the details on the receptor ligand expression and the peculiar phenotypes of cells, especially in the lung. Thank you.
Can I say one more thing? I think, again, I was going to say this. I think some molecular analysis, serial molecular analysis of these graphs in the belatacept treated patients would go a long way to helping define what's going on. Even in the BAL, if that's the best that can be gotten. But I think until we get those kind of serial analyses, I think we're going to be stuck scratching our head.
I cannot agree more. to that. That was a point I was going to make, that even if this was not collected in the trial, these patients generally have samples that are banked either for clinical reasons or other reasons through the HLA labs or through the histopathology core, that access to these samples to truly define serially what is happening would be key. The other point I wanted to add in that, in addition to this complexity of the lung coming with its own repertoire of cells from the donor, there's a complexity of just the lung being exposed outside. That complexity brings with all the infection risks that we have, and that interaction between the infection and this complex immune milieu, it's truly, we're just beginning to scratch the surface with these really seminal studies that are coming out now. So I think there's a whole lot more of an exciting area to learn in lung, to fully understand what is happening and how drugs like these could help us to treat our patients better.
Those are great points. Robin Voss, I'd really like to get your expertise and thoughts on this. In particular, in this study, belatacept was used early, but there's potentially other roles for it. And in particular, one thinks about antibody-mediated rejection, given the role of T-cell co-stimulation in driving antibody responses. I'm wondering what your thoughts are about uses of belatacept in terms of other rejection pathologies and how those might be unique in the context of lung transplant.
Yeah, thanks, John. So just for the viewers, maybe summarize. So the use of belatacept in this study was mainly in the first 3 months post-transplantation, actually as a replacement for MMF, which was later introduced. So the first question is this actually the best time window to use the belatacept? Because, I mean, when rejection, especially chronic rejection processes occur later during transplant follow-up. And for instance, with the belatacept, there is, with the co-stimulatory blockade, definitely an effect in follicular T helper cell and B cell interactions that you can or might block. But people have to keep in mind that, of course, the belatacept is not working for the plasma cells or the long-lived plasma cells, which are also probably involved in let's call it chronic AMR processes after lung transplantation. So that's a pathway that we actually are not targeting. And so one could think of its use actually in, let's say, AMR later after transplantation, or in chronic AMR or RAS, which is probably more the clinical phenotype of this chronic AMR process. There it might fit better than actually in this early post-transplant period. But still, I think it's as a sole treatment in this setting, it's probably insufficient. And probably we will need other drugs targeting also the plasma cells to actually reduce the production of the donor-specific antibodies. For instance, bortezomib and others. There are also new drugs coming to the market, and so I think it's an interesting, let's say, add-on treatment in the later phase post-transplant, but especially in the early phase, it's probably not that useful. And this is also shown in the study, by the fact that actually there was DSA production in the early periods. In the first 3 months, there were some DSAs detectable. However, this is typically in lung transplantation. Most new onset DSAs occur late after transplantation, let's say after the first 1 or 1.5 years. And so probably it would make more sense to position the drug rather in this time period after transplantation. Whether any of the other jury members or faculty have any comments on this, because I think it was the idea behind the studies is good, of course, but maybe it should be positioned later after transplant, actually in let's say more established chronic phase, especially if there is some B cell activation already, which you could target with belatacept.
If I may comment on that, I think you bring up a truly important point, that to try to figure out what the best timing for using these medications could be. And if you look at different cohorts, it seems the timing of the appearance of DSA varies from one cohort. I've looked at some of the European cohorts and some of the American cohorts, the timing of the development of DSA can be different. Should we time a drug like belatacept to that? I think that's a very interesting question. And the other dynamics that is important to raise is that if you look at lung transplant patients and you look at them prospectively over time, you look at markers that could suggest graft dysfunction at a clinical level, PFT, for example, or at a molecular level, cell-free DNA, for example, you see that these patients, their PFT tends to rise over time. You can give it an explanation that works. At the molecular level, you also see something else. Their cell-free DNA levels are high early after transplantation, and it seems to reduce over time, having an inverse relationship to the rise in the PFT. So is there a relationship between these molecular assessments and what we see clinically? I think these are really open questions. And Robin, I think you bring up a very important point, that in addition to figuring out this complexity of the immunology in lung transplant patients, figuring out this over time too, as Dr. Fairchild brought up, I think that could be important components before we could fully understand how best to use a drug like belatacept in these patients. Really good point.
Sean, if I can follow up on this, obviously you have done some seminal work with cell-free DNA. Can you comment more globally on the role of biomarkers in assessing the level of immunosuppression and how they can guide us in tailor therapy?
Yeah, so thank you, Dan. I'm going to try to do this in a minute or two, but you can imagine, hopefully we should organize a whole webinar to talk about how to, and Dr. Fairchild, this is his area of expertise as well. So it is, it is, can you imagine, it is fairly challenging. Here we are, we just spent about 27 minutes talking about the complexity of immune activity in the lung or in another solid organ. The question becomes, how do you then monitor that in a way that makes clinical sense? Currently, in lung transplant, we use drug levels. We look at tacrolimus levels in blood. We monitor antibody response and all of that. And I think increasingly we are recognizing that, yeah, that's good, but we need additional work. For example, you have patients who have adequate tacrolimus levels in their blood, but half of them or some percentage of them still go on to have rejection. Then the other percent don't get rejection at all. Then another fraction of those patients go on to develop opportunistic infections. So it would suggest that for that same level of tacrolimus, the degree of immunosuppression varies significantly from one patient to another. How can we then develop a biomarker that could adequately monitor immune responses in all patients? There's several ways to think of this. And again, this is all open for research. I think it's a fertile ground for research that we should hopefully jump into. But if we think that the goal of immunosuppression is to reduce allograft injury, could we identify then reliable markers that could measure allograft injury? And could those markers then be used to tailor immunosuppression, particularly if those markers can show changes that are clinically relevant way in advance to the detection of rejection? In my mind, that would be a biomarker that could be very useful. The paper that's published by Dr. Belpiro's group, I think they're beginning to really bring up some useful biomarkers that could begin to fit that kind of realm. The idea that you can get a biomarker that is dose response to rejection. You have mild rejection, the levels are low. Higher rejection, the levels are higher. Dose responses. Could these biomarkers also show trends that are significant, but prior to the episode of rejection? I think those would be good biomarkers to use for monitoring immunosuppression. The additional biomarkers that target specific arms of the immune system, T cell activation or B cell activation, I think these can be good biomarkers. However, given the complexity of the immune system, I think we need studies to actually show that these biomarkers that target specific arms of the immunity, that they could be useful to monitor immunosuppression in all patients. And I'll end by this biomarker, the one I work on quite often, cell-free DNA. It is a reliable marker for allograft injury. It picks up allograft injury that is clinically relevant weeks to months in advance before biopsy becomes positive. Could cell-free DNA be a reliable marker to monitor patients for immunosuppression? I think the jury is still out, and we need the studies to show that. So then I will stop here. Complex question. There's a lot of exciting research that's going on. I'm hoping to see what my other panelists think about this, but feel like it's a complex question. Thank you.
Thank you, Sean. I think Robin wants to comment.
Yeah, thank you, Sean. It's always interesting to hear talk about cell-free DNA as a biomarker. I think as a clinician, many of us are also looking not only at the trough levels of our drugs, but also at the lymphocyte counts, for instance. And I mean, it's astonishing to see how much difference there is between patients with the same trough level in lymphocyte counts. I mean, this does not relate to their activation status, but it is, let's say, maybe also a good biomarker to look at the absolute lymphocyte count in our patients and to see whether these are adequately, sufficiently suppressed or not. Is there any comment maybe on this and how this would relate maybe to the cell-free?
So, Robin, I think your voice was muted in the last section of this, so I did not completely. Could you repeat the question, please? I apologize.
Sorry, so I alluded to the fact that lymphocyte numbers or counts are actually, let's say, in circulating lymphocyte numbers are actually also maybe a good biomarker to look at. And is there any relation with the cell-free DNA levels? Do you know whether they relate? I mean, if the lymphocyte counts are high, cell-free DNA is also high, you know?
Yeah. So, and that's, again, that is, the jury is out on all of that. I think you're quite correct that these are things that we need to fully understand before we can before we can use some of these biomarkers in this light. However, I think there's good news though. The good news is that we are beginning to develop really large, well-phenotyped lung transplant cohorts. Dr. Greenland, for example, has a very big cohort at UCLA. The CTOT group, as you know, have multi-center, really large. The NIH with the GRAPH Consortium, Genomic Research Alliance for Transplantation, have large consortium. Robin in Europe is actually with colleagues there building a really large consortium of multiple well-phenotyped patients. I think the time for lung transplant is now. These are critical questions that I think we can answer, and we can answer them now. So, Robin, I think these are really good questions. We are all in the same boat together. I feel like the resources are there now, that hopefully in a few years or so, we should know some of these answers with some granularity.
I'm actually at UCSF, but I wanted to follow up one point there that you raised that was really interesting, right? The variability in terms of immune responses for people at a fixed level of tacrolimus in their blood has actually been shown in a few studies that either when you look by the Silex immuno assay or there's an assay of the mean residual expression of NFET-dependent cytokines in terms of T cells after stimulation, that you can see this huge amount of variability across individuals in terms of the amount of residual immune response they have at a fixed dose of tacrolimus, which has always been a strange phenomenon because while it's easy to observe, it's really hard to relate those to who exactly is going to get rejection. It's easier to show that that's linked to infection risk. And our ability to tailor immune suppression still is lacking. But, I think, that's sort of the hope with additional biomarkers that eventually we're going to be able to get there.
Can I ask a question, or do we have the time? I want to ask a question and see whether I could get the panel and Dr. Fairchild's opinion. What do you think about approaches that monitor immunosuppression, targeting specific arms of the immunity? How do you think about what we need to how we should think about those approaches. That's number one. And number two, the kinds of work that we need to do to show how useful those approaches could be.
Well, I think that's ripe for a non-human primate study myself right off the bat. So you can control what you're putting into them and the levels and things like that. I must admit, I'm not as conversant with lung transplants, but you know what CNIs do to kidney transplants and the injury they cause. And I'm sure that probably the same thing happens in lungs too. I agree with you. This is going to be really important to understand how these toxic drugs affect the kidney tissue and how they mold the immune response as well, because so many immune responses are resistant or less sensitive, I guess is a better term, to these.
Well, I want to make sure we have a good chance to talk about both of these papers. So maybe we can ask a question specific to this CXCR3 study. Christina, are you there?
I think we could ask Robin the question, John. I think she's off the call right now.
Okay, great. Yeah, I mean, this study is looking at the association between CXCR3 chemokines and allograft pathology. And maybe you could just explain to us a little bit about what these chemokines are, why these chemokines in particular, what this pathway says about transplant rejection, and are there other pathways that might provide complementary inflammation?
Yeah, thank you. So maybe to go very brief, I think these are two main chemoattractants to attract monocytes actually, and we know that these play a role in the process of rejection or inducing allograft injury. Actually, our group also in the past already demonstrated that these cytokines are involved in clot, or mainly in rust. They were upregulated, and so it's an interesting, let's say, pathway to look at, because of course these are very specific chemokines that you could block with monoclonal antibodies, and this way maybe attenuate the let's say pro-inflammatory milieu they're creating. So I think it's a very interesting pathway to look at, especially because it's been now shown in several studies that it's really involved in the process of chronic rejection or acute, or sorry, lung injury. And so in this way, it's a really interesting study because it opens another window on possible treatment options. I see Christina's back. Maybe she has also some additional comments on this.
Yeah, I mean, Christina, could you give us your thoughts in terms of what components of graft rejection are captured in CXCR3 and what parts of those pathways are missing?
Yes, thank you very much. This is actually really something that's driving me around in this context of inflammation, because you can see different papers, different organs, where expression profiles, protein analysis, in the kidney urine analysis, they come up with CXCL9 MIG or CXCL10 IP10. And you would call them almost the usual suspects, which is a title that, John, you prefer often for the lectures at RSHIT. And I would guess these are usual suspects, as if they are usual suspects, these two chemokines. I'm wondering why this is. And so I think there are two aspects. One aspect is that these are general chemokines that can recruit CXCR3 positive immune cells. Among those, there are T cells, NK cells, and primarily, but not only those. And we were wondering in different organs, and we published that for the kidney. Now we're looking in the lung, whether non-immune cells like endothelial cells, epithelial cells are able to secrete those chemokines, and actually they can. Because they seem to be, to me, my at the moment personal perception would be, they seem to be to me like innate responding chemokines. If you treat a epithelial or an endothelial cell not well, you stress it with DAMPs or with DAX signaling with MHC molecules or with other stressors, IL-6, IL-1, you can induce those chemokines. And I think this is for a reason, because it's like the initial call for immune cell recruitment at the CXCR3 site. And this is, I think, why many organs seem to be able to respond to an attack, whatever that may be, to a danger signal, let's put it like this, and then the organ responds. So it's not only the immune system that's producing and using those chemokines, it's especially also the endothelial and epithelial part. And if you consider this, then it makes sense that they come up as signals in different transplant settings. Phil Halloran has seen them in the kidney, then also Kieran Haravan has seen these chemokines in the heart. Now they are coming up in the lung, and the bronchoalveolar lavage, where you have the epithelial layer with the mucus and the cells that might produce those. So this is something where I would say, aha, here they are again. And this is for a good reason, because the cells feel the stress from the immune cells that are mediating rejection. And so this is like an amplifying system probably to the response of those immune cells, where the natural idea of these non-immune cells would be to call for help if there would be an infection. But in this situation, unfortunately, we do have rejection by the recipient immune system. And that is why they still have their program. And then they try to recruit immune cells by these chemokines, but they are doing that for the wrong purpose, because then it would probably lead to more rejection. So this is the idea that I try to create myself around those chemokines. And of course, there are others that could potentially even balance those. There's also a mechanism that's called fugitaxis, which is sort of, we always think that chemokines create a gradient, and then the immune cells are crawling along the gradient and going into the tissue. But this might be counteracted by the concentrations as such. So there might be an optimum. And if you're too high, then the immune cells may turn around and leave. This is what we learn from tumors, for example, that it's not only that you always follow the gradient up to the maximum. There could be a microenvironment where it's even too much and then they go back. So these chemokines, I think, are really key regulators of the microenvironment, and the question which cells are going into the tissue and what are they doing there. But there could be others that contribute, but it seems that the two CXCR3 receptors are always, ligands are always coming up as signals, probably due to the amplification of the tissue. Maybe others like Robert or Robin would have other kind of ideas, but that's what I would like to share with you in that context. Thank you.
Thank you, Christine. Rob, I have a question for you regarding how the immune requirements of different organs towards rejection and tolerance may be different, and the lung may be quite different from other organs that are not exposed to the environment. And our research and research from many others in mice has shown that the immune mechanisms that lead to rejection of these grafts differ from kidneys, for example, or hearts, at least in mouse models. And there was this editorial written about the belatacept paper in AJT by Ken Newell and Chris Larson entitled Great Expectations, where we take lessons learned in other organs, in this case, the benefit trial, for example, and try to adapt it to lungs. So I just want to hear your thoughts about the design of organ-specific immunosuppression and where the lung falls in that spectrum.
Well, as I see it, I think it's pretty obvious that the immune response to alloimmune response to any organ is going to be quite different. The response to a kidney or a heart is going to be a lot different than to a lung or to an intestine. There's a higher degree of inflammation that accompanies the transplant of those. The patients are really, really sick and have all kinds of antibodies. Not only do they develop to DSA, but they develop to autoantigens, and often they have those to begin with. So I don't know what you want me to say or asking me to say. I think it's obvious that they are going to be different.
I think Robin just raised his hand.
Yeah, maybe if I may follow up on both the previous faculty members, I think what we kind of forgot in lung transplantation is actually two things. One is the NK cells. I think we've been focusing a lot on T cells, but we've lost the NK cells in the entire story. And I think this is now again put back in the spotlight with these chemokines and other studies showing that NK cell activation is really important also in rejection. And the second thing is that we maybe also should not forget that the lung actually has the largest vascular bed of all transplanted organs. Thus, I mean, processes which affect the blood vessels, the endothelium, they're probably equally or more important in lung than, let's say, for instance, in kidney or heart transplantation. I don't know whether any of the other faculty members can agree on this, but I think these are things that are now becoming more and more evident with the research in the past years.
Well, along those lines, the papers that came out of UCSF with the role of NK cells, John's papers in primary graft dysfunction, which is obviously linked, I think, to augmenting an alloimmune response. Along those lines, should we think about, because obviously there's a link between lung injury, and John Belpiero has done seminal work on that, and the alloimmune response. Should we start thinking about targeting the innate arm of the immune system in lung transplants? Sean, what do you think?
Yeah, if I may, I think that these are really important studies that are coming out now, really pointing to this fact that you raised, Dan, that the lung is different. The lung is a different organ. It's not only different because it's up in up in the chest and exposed out there. The immune system is very different. The lung comes with its donor repertoire, and this interaction, the recipient, the donor, plus the environment, plus infection, opens really new opportunities that I think it's becoming clearer to the lung transplant community that we need to go back to the basics and define to define these interactions. So you raise up a good point. I think we need to do the studies in lung. It would be very challenging, in my view, to directly translate findings in kidney to heart. Those are important findings that our colleagues in the kidney literature, in the heart literature are developing. But we need to somehow figure out a way to translate that given the complexity of the biology in lung transplantation.
Christine?
Maybe I can just add to that. I couldn't agree more also on the innate part, which is you could talk about innate from two aspects, the innate cells. And I would agree that the NK cells may play an important role because we've shown that the NK cell repertoire in the lung, these are reflecting in principle the peripheral NK cells, so the CD56 DIMs, and not the ones that are sitting in the lymph nodes or in the liver, which would be the CD56 brights. And this interaction may be important. So the NK cells might be another player that also could regulate, because a lot of labs have shown that NK cells could control autoreactive T cells. So there might be even like a counter strike from the organ. But if we would know whether this is the case, we could enforce the counter strike to have like a balance of forces so that there is sort of a peace agreement, at least at the NK cell part. And the other innate would be then the innate signaling, like all the DAM signaling and the innate signals, including IL-1 signaling and so on. And there are also drugs that could probably interfere with, or even small molecules with signaling in that area. So I think a deep understanding, as Sean mentioned, and also the others, of what is the cells in the lung and what are the mechanisms that activate innate immune cells, but also endothelial, the endothelial interface could be something where we could add on to just try to think to suppress the effector cells coming into the lung, but also make use of the cells that are coming with the lung, and even more try to get the endothelial response better under control, because that might be one of the first interfaces that are attacked or under pressure in lung transplantation. And I do think, I've not been working in the lung before, but the more I enter the field, the more I get excited about this organ as an interface, also with the airway compartment. Thank you.
Can I just take us back to Rob and Boston, some of the work you guys have been doing in terms of other branches of the immune system that might not be measured here, independent of interferon gamma and type 1 immunity. People also talk about allergic Th2 responses and also Th17 responses. Th17 responses used to be talked a lot about in lung transplant, and I'm not sure we discuss them as much anymore, but what's your sense as to the extent of our ability to quantify these and treat these today?
Yeah, it's a good question. I was just trying to raise my hand on this. I think the question from Daniel on the innate immune cells and then also from Christina. I mean, we are actually already targeting innate immune cells, being the neutrophils and the which are often driven by Th17s. But the neutrophils, we are actually targeting with the azithromycin in lung transplantation, which at least in our center is given prophylactically or preemptively. In other centers also maybe, or when rejection is present. But I think there are options to target these cells, also mast cells. I mean, we know they are involved in the process of, let's say, innate immune activation, and there are drugs which may also help to let's say attenuate their activation. So I think there are many key possibilities to target the innate immune cells in lung transplantation, rather than just looking at the adaptive immune system or let's say regular immune suppressors.
And then can I ask you one more question on this? This paper really focused on the association between these interferon-dependent chemokines and a variety of pathologies that are seen on transbronchial biopsy. And I think we have a sense of acute cellular rejection and perhaps airway specific rejection as being important pathologies. But how is our understanding evolving about the variety of pathologies we can see on biopsy, and what are the relative merits of these? In particular, here where organizing pneumonia was seen frequently and not necessarily associated with increases in the CCR3 cytokines.
It's a good question, a very relevant question. I think we and others have shown that organizing pneumonia is actually not that harmless if you detect it, let's say, late after transplantation. This often is a kind of sign of graft injury. I mean, there's something going on. Either this is related to an infection or to the process of rejection. And we know that patients who are diagnosed with organizing pneumonia late after transplantation actually tend to develop more tend to develop clot or have a worse outcome. I mean, in the early post-transplant period, the organizing pneumonia can still be due to the transplantation procedure, the ischemia reperfusion injury, and there it seems to be less of a predictive marker. But I mean, there's so much more than just looking at perivascular lymphocytes. If for the pathologists, really, they really need to screen the biopsies also for AFOP or organizing pneumonia, because it really has a clinical relevance regarding the outcome. Treatment is difficult. I mean, there's no gold standard treatment for this. Most centers will probably increase their steroids a bit or adjust their immune suppressives, or treat infection if it's present. But I mean, it's really something to look for rather than just the A and the B grading. I think also every histologist, pathologist should really look for assessment of DADs, outdoor damage, organizing pneumonia, AFOP, and these things in the biopsies if possible.
And I think one thing that is, we're on the cusp of starting to use spatial transcriptomics, where we can look actually in a biopsy and see what transcripts are associated with specific or particular cells in the biopsy. A lot of us are doing that now. I think what we're going to see is that there's a lot of heterogeneity between people, because people are heterogeneous. But I think the other important thing, which goes to something Sean was alluding to, is can we use some of that transcriptome analysis and develop biomarkers that are then non-invasive biomarkers in urine, BAL, blood, things like that. So I think we're about to enter a very exciting period where we start to dissect this, but I think we're going to need a lot of aspirin because I think it's going to get even more complex than what we think.
Christine, I think you raised your hand.
Yes, Robert, exactly. And I think that we will learn a lot. The question would be, though, how much of that will be then seen systemically? And that was also nice in that paper that they could show that these chemokines are even high in the blood, because we always are struggling with the question in the blood, how much of that can reflect what's happening in the tissue. And I think there are some candidates, and I totally agree, if you have the money, so to speak, if you could spatial transcriptomics at that level in human tissue, you would learn a little more about the biology, and at the same time try to figure out how much of this can be translated systemically so that we would have less invasive biomarker candidates. And I'm also looking forward to this new era of the single cell transcriptomics that will show us which cells are contributing, and they may be more than we would argue from our sort of immunological point of view. Thank you.
I think the hour is almost up, and I want to thank all of our panelists for this great discussion. And I think what became very clear is that lung transplantation is an exciting field to be in right now. I think we're breaking new ground, and obviously there's a lot of room for improvement. And it's a nice field where research and clinical care intermingle very nicely. And on behalf of the American Journal of Transplantation, I want to thank our panelists again and everybody who attended this panel. I don't think there were any questions from the audience. So with that, thank you very much.
Thank you.